The PA oblique projection, RAO and LAO position. This view is used most commonly to assess for pars interarticularis defect, although this has been largely superseded by CT and MRI. Additionally, it is a frequently used view for needle placement in fluoroscopic guided procedures such as transforaminal epidural steroid injections. The image receptor to be used is a 10 by 12 inch image receptor, or 11 by 14 inch, or 14 by 17 inch image receptor, which is oriented lengthwise. For the L5 to S1 zygophysial joint, the image receptor to be used is an 8 by 10 inch or 10 by 12 inch image receptor. So in positioning the patient for PA oblique projection, RAO and LAO positions, the patient is examined in an upright or recumbent position. So in this case, as you can see, the patient is in the recumbent position. So the recumbent position is generally used because it facilitates immobilization, greater ease in positioning, and the patient resultant higher percentage of success in duplicating results make the semi-prone position preferable to the semi-supine position. However, the OID is increased, which can affect higher resolution. From the prone position, have the patient turn into a semi-prone position and support the body on the forearm and flex the knee. Align the body to center the L3 to the midline of the grid. Note that the umbilicus is used as a landmark to locate the L3. Adjust the degree of the body rotation to an angle of 45 degrees. Take note that an oblique body position of 60 degrees from the plane of the image receptor may be needed to show the L5 to S1 zygophysial joint and articular processes. Then, center the image receptor at the level of L3. The lumbar region, have the central ray positioned perpendicularly to enter the L3, that is 1 to 1.5 inches or 2.5 to 3.8 centimeters above the crest of the ilium. The central ray enters the elevated side approximately 2 inches or 5 centimeters lateral to the palpable spinous process. For the L5 to S1 zygophysial joint, the central ray is directed perpendicularly to enter the elevated side 2 inches or 5 centimeters lateral to the palpable spinous process and to a point midway between the iliac crest and the ascis. For collimation, adjust the field size to 9 by 12 inch for 10 by 12 inch image receptor, 9 by 14 inch for 11 by 14 inch image receptor, or 14 by 17 inch image receptor. And for the zygophysial joint, L5 to S1, have it collimated to 8 by 10 inch. Structures shown are the following: area from the lower thoracic vertebrae to the sacrum, oblique projection of the lumbar or lumbosacral vertebrae showing the articular processes of the side farther from the image receptor, the T12 to L1 articulation between the 12th thoracic and the first lumbar vertebrae, having the same direction as those in the lumbar region, which is shown on a larger image receptor. The vertebral column parallel with the tabletop so that the T12 to L1 and L1 to L2 intervertebral joint spaces remain open. The fifth lumbosacral joint is usually well shown in oblique positions. When the body is placed in a 45-degree oblique position and the lumbar spine is radiographed, The articular processes and zygapophyseal joints are shown. Images of the lumbar vertebrae have the appearance of the Scotty dogs, is seen properly positioned. The following are the anatomic components of the Scotty dog. Take note of the following. When the joint is not well seen and the pedicle is quite anterior on the vertebral body, the patient is not rotated enough. When the joint is not well seen and the pedicle is quite posterior on the vertebral body, the patient is rotated too much.